Good day everyone, and today we will talk about the sensory and motor or secretomotor control over all structures of the head provided by the cranial nerves. We'll discuss the functional composition, peripheral and central attachments, and of course the cores of each cranial nerve. So let's begin. Cranial nerves may carry one or more of the following functional components. There are several types of the motor and sensory fibers. First of all, the motor fibers to voluntary muscles, which include the somatic motor or general somatic efferent axons. These axons form the 3rd, 4th, 6th, and 12th cranial nerves. The muscles which derive from the pharyngeal arches in the embryo, such as the muscles of mastication or muscles of facial expression, are innervated by the special visceral efferent fibers. The cranial nerves related to the branchial arches include these types of fibers. These cranial nerves are the nerves number 5, 7, 9, and 10. The motor fibers involved in innervation of involuntary, smooth muscles and glands include general visceral efferent axons and constitute the cranial outflow of parasympathetic division of the autonomic nervous system. The cranial nerves number 3, 7, 9, and 10 carry these fibers toward the corresponding parasympathetic ganglia to synapse on. The postganglionic axons supply the glands and smooth muscles. The fibers transmitting general sensation such as proprioception, touch, pressure, heat, and cold from the skin and mucous membranes include somatic afferent or general somatic afferent fibers. These fibers are carried by cranial nerve number 5, but also by the cranial nerve number 7, 9, and 10. Fibers conveying general sensation from the viscera include visceral sensory or general visceral afferent fibers, conveying information from the carotid body and sinus, pharynx, larynx, trachea, bronchi, lungs, heart, and gastrointestinal tract. For transmission of unique sensations, we have special sensory fibers. The special visceral afferent fibers for conveying of taste and smell, and the special somatic afferent fibers for the special senses of vision, hearing, and balance. Each cranial nerve has a peripheral and central attachments. The peripheral attachment may be a muscle fiber or a receptor cell, that means the structure supplied by the nerve, while the central attachment is one or another nucleus in the brainstem, exception for the first two cranial nerves, which involve extensions of the forebrain. The cranial nerve nuclei are groups of neurons in which sensory afferent fibers terminate and from which motor efferent fibers originate. Nuclei of similar functional components, for instance somatic or visceral motor or somatic or visceral sensory, are generally aligned into functional columns in the brainstem. The cell bodies of the general somatic efferent neurons are located closer to the midline of the brainstem. Lateral to them are the bodies of the somatic visceral efferent neurons supplying the branchial muscles and the secretomotor parasympathetic neurons. The bodies of the sensory neurons and their nuclei are mostly on the periphery of the brainstem. Our goal today is to follow the cranial nerves from their central to peripheral attachment and to review all possible clinical correlations of each cranial nerve. We'll start from the simplest sensory and motor nerves. The filaments of the olfactory nerves, 15 or 20 pairs of them, are the central processes of bipolar receptor cells located in the mucous membrane of the upper nasal meatus, called olfactory nasal mucosa. The bundles of central processes pass through the cribriform plate of the ethmoid bone, entering the anterior cranial fossa. Olfactory nerves are the exceptions to the rules. They are not attached to the brainstem, but directly to the elongations of the telencephalon, known as olfactory bulbs. The olfactory bulbs are composed of the mitral cells, Those central processes form the olfactory tracts. Olfactory tracts are connected with the primary olfactory cortex located in the uncus of the temporal lobe. Anosmia is a result of lesion of the olfactory filaments that is common in fractures of the anterior cranial fossa. Embryologically, the eye, retina, and optic nerve are the elongations of the diencephalon. It is not a peripheral nerve, it is a central tract, which, as well as other tracts of the central nervous system, is covered by oligodendrocytes and may be attacked by multiple sclerosis. The optic nerve is formed by central processes of ganglion cells of retina, which perforate the lamina cribrosa in the sclera of the posterior surface of the eyeball, leaves the orbit via the optic canal, and extends till the optic chiasm, where inner fibers cross the midline and enters the optic tracts on the opposite side. The optic tract reaches the lateral geniculate body of the thalamus, the airway synapse. The central processes of the lateral geniculate body, neurons, form the optic radiation that reaches the primary and associative fields of the visual cortex. Any part of the optic pathway may be damaged, leading to specific defects or full loss of one or both visual fields. Lesion of the optic nerve leads to total loss of vision on the same side. The condition is called ipsilateral or monocular blindness. The possible cause of damage is compression by the excessive cerebrospinal fluid, as in hydrocephalus, or disorders of the blood circulation, for example, obstruction of the central retinal artery and vein. The optic chiasm pituitary gland is located just behind the optic chiasm, and it can press the inner fibers of the optic nerves in case of hypertrophy or tumor of the pituitary gland. The inner fibers of the optic nerves are the central processes of the retinal receptor cells on the nasal half of the retina, which receives the light from the temporal visual fields. Compression of these fibers will lead to loss of the temporal visual fields on both sides. The condition is called bitemporal hemianopsia, and this is a specific sign of the tumor of the pituitary gland. The optic tract pathology leads to loss of half of the contralateral visual field in both eyes. It is called homonymous hemianopsia. Damage of proximal part of the optic radiation by tumor or stroke leads to loss of the upper quarter of the opposite visual field of both eyes. It is called left superior quadrantopsia. Damage of distal, precortical or cortical parts of the optic radiation by tumor or a stroke, for example, leads to homonymous hemianopsia with macular sparing, when even with loss of the half of the opposite visual field, the acute central vision remains adequate due to overlapping of the visual fields of the right and left eyes. The related terminology is described in the notes. The vestibulocochlear nerve is special somatic sensory nerve too. It is formed by the central processes of the receptor cells in the inner ear and is conveying the sensation of hearing and equilibrium. The central processes that form the cochlear nerve relay in the spiral ganglion and passes via the anterior-inferior quadrant of the internal auditory meatus. The cochlear nerve enters the pontomedullary junction laterally and relays on the ventral and dorsal cochlear nuclei, which span the junction of the pons and medulla. The vestibular nerve, formed by central processes of the sensory macula in the vestibular apparatus and the cupula of the semicircular canals, relays in the vestibular ganglion of Scarpa, and passes via the posterior half, superior and inferior quadrants of the internal acoustic meatus. Axons of the vestibular nerve synapse in the four vestibular nuclei, medial, lateral, superior, and inferior, which are found on the lateral floor and wall of the fourth tentacle in the pons and medulla. Some vestibular tracts begin here, such as vestibulospinal, that is responsible for the support of balance against the gravity, vestibulocerebellar, which coordinates the movements of the body, vestibulocortical, allowing to realize position of the head, and vestibulo-oculomotor tract, which coordinates the movements of the eyes and head for stable fixation of gaze during the head or whole body movements. The oculomotor nerve is formed by peripheral processes of the somatic motor neurons located in the nucleus of the oculomotor nerve and by visceromotor axons arising from the nucleus of Edinburgh-Westphal. Both nuclei are located in the midbrain at the level of the superior colliculi. The nerve leaves the midbrain, passing between the cerebral peduncles through the interpeduncular fossa. There it has a close relationship with the vessels of the circle of Willis, namely with the posterior communicative artery and posterior cerebral artery, with the superior cerebellar artery. Dilatation or dissection of any of these vessels may involve the oculomotor nerve. Thus, the nerve root consists of the visceromotor and somatomotor fibers, which are arranged in a specific order. The parasympathetic fibers cover the somatomotor above and on both sides, so the motor fibers are hidden inside the nerve. This distribution plays an important role in diagnostics. If the oculomotor nerve experiences some pressure from above, that may be by a herniation of the temporal lobe or a tumor, the parasympathetic fibers suffer first, and such patient will have paralysis of accommodation and dilated pupil on the site of lesion. The sign is known as internal ophthalmoplegia because the ciliary and sphincter papillae muscles are supplied by these fibers. In case of chronic neuropathy, such as in diabetes mellitus, the deep fibers suffer ischemia first, and a patient has ocular movements disorders first. The eyeball is rotated downward and inferiorly. The condition is called the external ophthalmoplegia. The nerve passes forward, piercing the subarachnoid space and dura mater at the level of the lateral wall of the cavernous sinus, and traverses this wall, passing above the trochlear and the first two branches of the trigeminal nerve. The sympathetic periarterial plexus accompanies the internal carotid artery in the cavity of the cavernous sinus, and sympathetic fibers follow some nerves, passing through the lateral wall of the cavernous sinus. In fact, the superior division of the oculomotor nerve and the nasociliary branch of the ophthalmic nerve do carry sympathetic fibers. The thrombosis of the cavernous sinus or carotid cavernous fistula can cause a lesion of these nerves. Close to the superior orbital fissure, the oculomotor nerve divides into two branches, the superior and inferior one. The parasympathetic fibers continues with the inferior division, while the sympathetic fibers with the superior one. Both divisions enter the orbit passing via the common tendinous ring and supply the oculomotor muscles. The superior division supplies the superior rectus muscle, levator palpebrae superioris, and the superior tarsal muscle of Mueller. The inferior division supplies the medial, inferior recti, and inferior oblique muscles, and gives off the preganglionic parasympathetic branches to the ciliary ganglion. The postganglionic mixed branches leave the ganglion as the short ciliary nerves and supply the sphincter papillae and the ciliary muscles of the eye. The dilator papilla receives sympathetic innervation from the long ciliary nerves, branches of the nasociliary nerve. The ciliary ganglion, as well as any other cranial parasympathetic ganglia, receives three types of fibers: sensory fibers, GSA, while the sensory ganglionic branch of the nasociliary nerve, sympathetic fibers from the carotid plexus, and parasympathetic fibers from the Edinburgh-Westphal nucleus via the inferior division of the oculomotor nerve. Only parasympathetic fibers rely on the ganglionic cells. Others traverse the ganglion without synapsing. That is why we generally talk about the parasympathetic input and output. The postganglionic branches are all mixed, but they include the postganglionic parasympathetic fibers. The outflow of the ciliary ganglion is represented by 15-20 short ciliary nerves, which piece the sclera and supply the sphincter papillae and ciliary muscles. The somatic motor neurons, which form the trochlear nerve, are located in the midbrain at the level of the inferior colliculus. Axons of these neurons run to the opposite side of the midbrain and appear below the inferior colliculus as the root of the trochlear nerve. The trochlear nerve has the longest intracranial subarachnoid path of all the cranial nerves, as it turns around the cerebral peduncle and passes forward between the vessels of the posterior circulation, actually between the posterior cerebral artery and the superior cerebellar artery, lateral to the root of the oculomotor nerve. Then it pierces the arachnoid and dura mater in the area of the lateral wall of the cavernous sinus. The nerve enters the orbit via the lateral part of the superior orbital fissure, outside of the common tendinous ring, then goes medially and supplies superior oblique muscle. The primary function of the superior oblique muscle is the intorsion, medial rotation of the eyeball clockwise, which leads to slight abduction and depression of the eyeball. The intorsion is opposed by the inferior oblique muscle, which provides the external, opposite of clockwise, rotation of the eyeball, called extorsion. If the trochlear nerve is damaged, the eye remains extorted, and others do not well notice that. However, that leads to diplopia, the double vision, as the visual axes of the right and left eyes are not parallel. To check the trochlear nerve function, ask the patient to look at the tip of his or her nose, in anatomical terms to depress the adducted eye. The main eye depressor, the rectus inferior, is ineffective in the adducted position. Thus, the depression of the eye depends only on the superior oblique now. The root of the abducent nerve is formed by the peripheral processes of the somatic motor neurons, which make the abducent nucleus in the lower part of the pons and arises from the pontocerebellar angle, close to the midline. The nucleus has close relationships with the root of the facial nerve, which winds around the abducent nucleus, producing facial colliculus in the floor of the rhomboid fossa. The abducent nerve then goes upward and forward along the basilar part of the occipital bone, reaching the upper margin of the pyramid of the temporal bone. Then it enters the middle cranial fossa, entering the cavity of the cavernous sinus. However, it pierces the dura mater much earlier, while ascending along the clevus of the occipital bone. Here it perforates the meningeal layer of dura mater and passes further through the dural canal called Darell's canal, which opens into the cavernous sinus. The nerve is vulnerable, crossing the sharp superior margin of the pyramid of the temporal bone. There, the nerve is breached by a petrous sphenoid ligament, thickened part of the dura mater. If the intracranial pressure increases, the nerve may become compressed at this point. The second place that the nerve may be damaged is the cavity of the cavernous sinus. Unlike the other cranial nerves passing through the lateral wall of the cavernous sinus, the cranial nerve number 6 crosses its cavity together with the internal carotid artery. The abducent cranial nerve enters the orbit through the common tendinous ring and then deviates laterally to supply the lateral rectus muscle. Lesion of the abducent nerve leads to the development of the medial strabismus. The eye is rotated medially due to the unopposed function of the middle rectus muscle. Diplopia is also present.